Hello everyone, this is Dr. Madhusudhan Rao, retired professor of pediatrics. On the topic, I teach medical students. Today I am going to talk on cyanotic spell, which is also called as TET spell. In this short video, I am going to give you a brief account of cyanotic spell. It occurs mainly in the children with tetralogy of Fallot. It is a medical emergency. What is tetralogy of Fallot? Tetralogy of Fallot has got four congenital anomalies. Number one, ventricular septal defect, pulmonary stenosis, overriding of the aorta, and hypertrophy of the right ventricle. And it is the milder form of the tetralogy of Fallot. This cyanotic spell occurs in the children around the age of 2 years. You look at this picture. The child with tetralogy of Fallot with bluish skin during the episode of crying and feeding. So it is also called TET spell. You see the bluish discoloration of the lips and bluish discoloration of the extremities. Child appears to be dyspneic with indrawing of the chest. This is another child with the tetralogy of Fallot admitted for cyanotic spell. Then look at the heart with the tetralogy of Fallot. There are four components, as I mentioned earlier. The diagram shows ventricular septal defect, pulmonary stenosis, overriding of the aorta, and hypertrophy of the right ventricle. What is happening in the tetralogy of Fallot? What are the hemodynamics? The venous return occurs as usual from the superior and inferior vena cava into the right atrium. From there, blood flows into the right ventricle, and right ventricle, there is an obstruction in the outflow tract that results in the resistance for the emptying of the right ventricular blood into the pulmonary trunk. Because of this, right ventricle undergoes hypertrophy. As the pressure is mounting up in the right ventricle, the blood flows from the right ventricle into the overriding aorta through the ventricular septal defect. So the deoxygenated blood being pumped into the aorta, resulting in cyanosis. And because there is deoxygenated blood flowing in the systemic circulation, there is a degree of hypoxia. This is aggravated during the patient with tetralogy of Fallot. There is severe spasm of the right ventricular outflow tract. And during crying, there is increased venous return to the right heart. Combined together, the more amount of blood flows into the overriding aorta through the ventricular septal defect. That results in the systemic hypoxia, metabolic acidosis. And the consequences of metabolic acidosis as a tissue injury. Even the myocardial cells can injured, resulting in consequences of myocardial damage and death. There is systemic vasodilatation as a consequence of hypoxia, and there is increased venous return, and there is pulmonary vascular constriction. All this leads to the mounting up of hypoxia secondary to the increased sending of the deoxygenated blood from the right ventricle into the aorta. That's what happens in tetralogy of Fallot with cyanotic spell. As a result, child will be admitted with the signs of restlessness, dyspnea, irritability, and diffuse deep bluish discoloration of the mucous membranes and the extremities. Hypoxia may lead to sometimes convulsions and coma. This is what happens in the child with cyanotic spell. Let us look into some of the pictures, which demonstrates the anatomical abnormality. Like you can see in this picture, a section of the heart viewed through the right ventricle from the right side. This is the ventricular septal defect, an opening in the interventricular septum, and overriding of the aorta over the ventricular septal defect. There is right ventricular hypertrophy showing the chamber volume of the right ventricle is very less. There is pulmonary outflow tract which is very much narrowed. So there is obstruction to the right ventricular outflow tract, resulting in mounting of the pressure in the right ventricle, which in turn leads to the hypertrophy of the right ventricular wall. Yes. So most of the right ventricular output goes into the overriding aorta, thereby causing cyanosis and hypoxia. So there are other terms to describe the cyanotic spell. These names are like paroxysmal hypercyanotic spell, blue spell, tet spell, and hypoxic spell. These are the other names given to cyanotic spell. With all these abnormal hemodynamics, the child presents with restlessness, tachypnea, increasing cyanosis, and sometimes child will go into syncope, comes to the emergency with the history of seizures. These spells occurs in paroxysms, and children with a mild degree of tetralogy of Fallot, which is called the pink Fallot, they are more prone for cyanotic spells. The most common age of occurrence of this spell is around 2 years of age. And child following severe crying and waking up from sleep, they go into this particular spell. Okay? The onset is acute, following feeding and excessive crying. What happens during excessive crying? There is more negative intrathoracic pressure, and there is increased venous return to the right heart, which adds to the right ventricular output, which is not ejected into the pulmonary circulation. Instead, it is pumped into the aorta, resulting in systemic hypoxia and the manifestations of cyanotic spell. So, when you examine the child will be having respiratory distress and tachypnea, and deeply cyanosed and sometimes gasping. When they auscultate the heart, second sound is diminished in intensity because second sound is generated by the closure of the pulmonary valve and the aortic valve. There is no pulmonary component in this particular child because there is no right ventricular output in order to get the pulmonary component of the second sound, which is remarkably diminished, resulting in diminished intensity of the second heart sound. And the systolic murmur that you hear normally in the tetralogy of Fallot, it will be absent or diminished in intensity. And child may be in coma with some neurological deficit in severe cases. So with all this, when the child comes to the clinical emergency, to your emergency services, you are supposed to manage the child in the following lines. So remember, you have to correct all the abnormal hemodynamics in order to get the child improved. So number one is child is suffering from hypoxia. So you have to administer oxygen. Number two, child is having peripheral vasodilatation, systemic vasodilatation, and increased venous return. These can be corrected by keeping the child in knee-elbow position. By so doing, you are keeping the limbs flexed, that is, limbs flexed. Lower limbs are flexed at the knee and the hip, thereby producing some pressure or compressing the great veins and the femoral artery. The femoral vein and the femoral artery are compressed at the groin with the flexing of the hip. That results in the increased systemic resistance and reduced venous return to the heart. Then next, you have to allay the apprehension and anxiety of the child, and the increased irritability of the child can be controlled by administering morphine. Give the morphine in a dose of 0.2 milligrams per kilo body weight subcutaneously. So number one, you have kept the child in knee elbow position to reduce the venous return and increase the peripheral vascular resistance. You kept the child on oxygen to reduce hypoxemia, and you have injected morphine to reduce the irritability in the child. By so doing, the child will improve more or less in mild to moderate cases. In severe cases, when the ABG shows PaO2 less than 40 mmHg, then you have to go by sodium bicarbonate. Once you have corrected the pH, child will improve dramatically. Sometimes you may have to inject phenylephrine which causes the peripheral vasoconstriction, resulting in increased systemic resistance, thereby reducing the shunt from the right to left. And next, once child is improved, you can give the prophylaxis in the form of propranolol to the child. Then if the child is not showing improvement, in severe and resistant cases, you can intubate the child and treat the hypoxia. And in most of the cases, child will improve when admitted early and attended to effectively. Right. This is all about the cyanotic spell in children with cyanotic heart disease. So hope, my dear students, it is clear to you the abnormal hemodynamics of that spell and the where the child presents as an acute medical emergency and the steps of management you have got to take in order to avoid complications like neurological damage and cardiac arrest and death. Thank you very much for patient listening, and we'll meet again with the next lecture. Until that time, bye bye. Good day.